Okay, we're going to get started. And today right now, what we're going to be focusing on is childhood care. So for individuals with Duchenne who are between the ages of 9 and 15, my job is to introduce the panel of individuals who will be talking today. And then I'll step back and I'll moderate if there are any questions afterwards. So first of all, I want to introduce Owen, who's seated to my right here. So Owen is currently enrolled in the Game Art program at the School of Communications, Media, Art and Design at Centennial College here in Toronto. He's been a client at Holland Bloorview Kids Rehab Hospital and SickKids for 12 years' time, and he's going to be asking the initial questions of our panel today. Then we have Dr. Craig Campbell, and he's the medical director of the Multidisciplinary Neuromuscular Clinic based at Thames Valley Children's Centre and the Pediatric Neurophysiology Lab at Children's Hospital London Health Sciences Centre. Next to him, we have Dr. Reshma Amin, who's the director of the Sleep and Long-Term Ventilation Clinic at SickKids, and a senior associate science at SickKids Research Institute. She's a professor at the University of Toronto. Next to her, we have Charise MacDonald, who we heard from earlier today. She's an occupational therapist who has over 10 years of experience working in pediatrics, and she's been part of the neuromuscular team at Holland Bloorview for 8 years. Next to her, we have Dr. Leanne Ward, who is a Tier 1 research chair in bone pediatric disorders, a professor of pediatrics at the University of Ottawa. She's a medical director at the CHIO Genetic and Metabolic Bone Disease Clinic scientific director. Also the Ottawa Pediatric Bone Health Research Group. She's a pediatric endocrinologist in the Division of Endocrinology and Metabolism at CHIO, so Children's Hospital of Eastern Ontario. And at the end of the row here, we have Linda Fazari. She is a pediatric nurse practitioner in the cardiology unit at the Labatt Family Heart Center at the Hospital for Sick Children, and she holds a master's degree in nursing. So I think we have an absolutely wonderful panel today and an excellent moderator. So I'm going to let Owen come up and he can start asking questions.
All right. Hi, everyone. So the first question is for Dr. Campbell. From your perspective, what gives you the most hope right now for the future of Duchenne care and research?
Thanks everyone for having me here. Really grateful to Defeat Duchenne for asking me to be here. So that's a really good question, and I think we've seen today through the day that there's a tremendous amount of things to be hopeful for, both in terms of care and research, and it always inspires me to come to these meetings and just digest all the great things that folks are doing in all parts of our Duchenne community here in Canada. When I think about care, one of the more timely things that we've all celebrated this past week is the approval of vamorolone, and so. Maybe I'll start there because not only is vamorolone a great step forward in terms of options for our community, for the boys who are contemplating steroid usage or steroid equivalent usage, but we've heard about vamorolone, but it's also to me the fact that this is a first drug really specifically trialed in Duchenne that's finally been approved in Canada, and I know that's probably not lost on this audience how important that is. We have for years been a country that has outstanding standard of care, great collaboration in the Duchenne community. We participate in many, many trials. In fact, I would say really are leaders in the world for doing clinical trials in Duchenne, and yet we don't have, this is the first drug that's really been approved in Canada. for Duchenne, and so that's meaningful for us. It's meaningful because of the pathways that have to be journeyed along for all of us to get drugs approved in Canada. We know we still, with vamorolone's approval, still have some steps ahead. So I think that that's exciting for me that we have that milestone and can use that, because I think we now have to use that to leverage the next drug specific for DMD. And what do I mean by that? I think we need to tell that story. I think we need to really celebrate and engage with what's happening in the rare disease space more widely. I mean, obviously everyone here are strong advocates for DMD, but there's parallels and there's there's similarities, congruencies with what's happening in the rare disease space in Canada more broadly, and I really. In fact, up here with several people who put a lot of time and energy into fashioning and creating a rare disease space in Canada that allows us to get drugs like this to boys with Duchenne. So I think we need to really dive into that. We've seen glimmers of hope in Canada around rare disease. We have a rare disease drug strategy. Didn't fund any drugs for Duchenne, sadly, but it's coming up for renewal. In fact, we were just in Ottawa a couple of weeks ago speaking with Daniel MacDonald and Andrew Taylor, who guide that file for Health Canada. That's coming up for renewal. I think we need to, look at and get in front of those folks who make decisions about what drugs are going to be funded there. Vamorolone, why not? I mean, what a good, perfect timing around advocating for that drug. We need to, work with companies who are in that process to make that kind of approval for vamorolone more immediately valuable to boys. I mean, why isn't Kai got a managed access plan or free goods plan around vamorolone? For those boys who need it most, who have struggled particularly with with side effects, and we need to leverage things like our national neuromuscular disease registry to help facilitate those types of things. So, for anyone who knows me, I love to celebrate those things and then say, let's drive forward to the next thing. And so I think we need to take this approval for vamorolone and and drive forward to the next step. So I talked a lot about care. I didn't really touch on research too much, tons of research today. Maybe I'll just quickly say, I'm excited about a lot of things, despite some setbacks over in recent years in some of the clinical trials. I'm just thrilled to see the engagement from many large and small biopharmaceutical companies engaged in trying to make things better for DMD. It's so hard to say where the excitement is. I mean, anything, whether it's a genetic or gene-based therapy right through to a muscle modifier, as Laura so nicely painted the picture, has the chance to work really well and be a significant step forward for us. And it's so hard to know sometimes where we're going to see that. So I think the short answer to that question would be, I'm excited about how much clinical research and clinical trial opportunities continue to be available in the DMD community in Canada. And again, just want to echo, many people said it today, but thanks to the families who step into that, because it's not easy to be a part of a clinical trial. And I'm always very grateful and use it as significant motivation for what we do in London because of how invested, brave, and resilient all of you are. So thanks.
All right, thank you, Dr. Campbell. So next question is for Dr. Amin. This one's kind of like a two-part question. So, what progress have you seen in respiratory care, and how might this change what families can expect as their child ages?
Okay.
The second part, sorry, is we are encountering the flu and COVID season. What should families do differently if their child becomes sick with a respiratory illness?
Okay, thanks. Thanks, Owen, for those fantastic questions. I'll try to answer the first one first and then go on to the second, but I might need you to repeat the second one
That's
after.
fine.
So in terms of advances in respiratory care in the context of Duchenne muscular dystrophy, I think that there were these really important clinical practice guidelines that came out back in 2018. And in particular, if we focus on the respiratory care part of it, one of the new things that came about was really this push for respirology diagnostic testing to be pushed earlier and earlier into the lives of boys with Duchenne. So I think traditionally, when you meet a respirologist, you're sort of much more advanced in your clinical disease. And I think the thing that these guidelines push for is that you should already be having even when you're ambulatory, you should already be having regular lung function testing at least every year. And you should also be being screened for sleep disorder breathing with a full sleep study, also even when you're ambulatory. So that was a huge clinical practice change. And then even with that, so if we can see boys earlier, then we can identify issues earlier, and we can then start technology, which I'll talk about if needed, earlier, because at the end of the day, the goal is to keep kids out of the hospital at all times. Whereas if we weren't sort of screening for things early, then oftentimes kids were ending up in the hospital and having to start some of those therapies in the hospital for the first time. So that change in clinical practice guideline has really helped sort of push respiratory care to be more proactive as opposed to reactive. So that's, I think, the first thing in terms of screening. The second big change is that in those same guidelines, they also changed, they advocated for the initiation of non-invasive ventilation much earlier than traditional guidelines. So traditionally, when we have a sleep study that's done, it gets scored and reported in accordance with these other sets of rules called the American Academy of Sleep Medicine guidelines. But for years, respirologists who practice sleep medicine, look after neuromuscular patients, felt that, if we wait that long for these rules to come into play, we've sort of missed the boat in terms of really trying to start our boys with Duchenne earlier in sort of that proactive approach. Because we know starting a child and a boy on non-invasive ventilation, there's nothing about it that is easy for the child or for the family, and it's going to take time, months, even years, to get kids to tolerate this and to get families to tolerate with this. And so by the time we really need to be good and have the boys be adherent, this gives a bit of a landing pad. And so that's the other thing that these clinical practice guidelines advocated for, is sort of more, I would say, less severe findings on the sleep study, but still initiating therapy. So with these sort of changes, that's really been the biggest change in care. And so in terms of what you can expect as sort of boys with DMD and families, is that when you're coming to see your respirologist, they're going to be recommending these diagnostic tests, which will be lung function tests, including the ability to cough, and also screening for sleep disorder breathing in the form of sleep studies. And so in terms of technologies that we start, if there are any concerns, so typically in the setting of Duchenne muscular dystrophy, if there's going to be issues from a respiratory perspective, they're really going to be in one of two areas. So the first is going to be with trouble coughing. So when you cough, you have to take a big breath in, which uses your breathing muscles. You have to use your throat muscles to close your vocal cords, and then you have to use your breathing muscles in your chest again to sort of forcibly open those vocal cords and then cough. And so in boys who have Duchenne, they have weakness of those muscles, and as a result of that, they have a weak cough. So your respirologist can actually measure how strong your son's cough is. And we have sort of certain normative data that tells us when the cough is weak. And when the cough is weak, it's time to start these assisted cough techniques. And we have a different range. Sometimes it's a lung volume recruitment bag that you may have seen, and sometimes it's a cough assist machine. So the second is sleep disordered breathing. So when you are awake, we have our regular muscles of breathing, but we also can call in extra helper muscles to help us breathe. But when we go to sleep, because we're asleep, we're losing those extra helper muscles, and in particular, in a type of sleep called our REM sleep, so our rapid eye movement sleep, we only have our diaphragm helping us breathe, and that is all. Which is why if anyone is going to run into trouble with breathing, they are always going to run into trouble with breathing first during sleep, which is why we need to screen boys with sleep studies. And so if we see obstructive sleep apnea, so a collapse of the upper airway, then the treatment of that might be to start a non-invasive ventilation, or it might be to have the tonsil and anodes taken out. And if we see on the sleep study that there's hypoventilation, which is when the body can't get rid of carbon dioxide effectively, that's another indication for ventilation. So those are the technologies that you could expect to be sort of discussed and started. But really the big change is that we're sort of diagnosing and screening boys much earlier and then putting kids onto treatment earlier to help be preventive and less reactive. Yeah, it's a good question. And so it's completely variable based on multiple factors. I think just in terms of when your child started on Duchenne care, did they receive steroids? And so some children may still be ambulatory, okay? And they may have obstructive sleep apnea, even with completely normal lung function. In part because, remember, they're still boys and they can have large tonsils and adenoids, which is what also boys with Duchenne muscular dystrophy have that contribute, in addition to sort of the weaker upper airway muscles. So I think it's variable in terms of things, but you know, it's typically in the second decade. But we have seen boys that we've had to start sort of technology on who are younger. And then in terms of the second question, that with flu and COVID season around the corner, what are some recommendations for children and families if they do get sick with colds? I think, was that the question?
Yeah.
Yeah? Okay. So I think the first thing, and Dr. McAdam touched on this earlier today, is prevention, prevention, prevention. So good hand washing, believe it or not, goes a long way. So really reinforcing that with your son and reinforcing that with the family is really important. The second is vaccination. So if this fits with sort of your family's approach to care, as a respirologist, of course, I do strongly recommend vaccination. So flu shots for the child, but also for the family, and similar with the COVID vaccination. Also, for all of our patients that we follow with Duchenne, we also recommend the pneumococcal vaccination. So those would be 3 vaccinations to speak to your healthcare providers about getting. If your child does get sick with a cold, I would say follow your parental instinct in terms of where things are, because you, of course, are the expert in your child. So if they have a fever, give them antipyretic medicine to bring down the fever. If they don't want to eat, that's okay, just keep them hydrated. The most important thing to remember is that you do have a healthcare provider team that you should not hesitate to reach out to at any time if you don't know and if you're worried. And 8 o'clock in the morning and your son is seeming to be more lethargic or tired or breathing in a funny way, you know, don't doubt your instinct and don't hesitate to take them to the emergency room if you need to, okay? So hand washing, vaccinations, good hydration, managing the fever. The other thing that I think is really helpful for families to practice is getting a sense of what your child's normal breathing rate is and what their normal work of breathing is. So the best way to do this is to get a sense of what things are like when things are good. So just before bed, just before they get into bed, have a look with their shirt off what their breathing rate is. The next time you go see your respirology provider, they can help teach you how to count the breathing rate for your children and also see what normal work of breathing is. This is probably the most reliable sign for you to look at if you think that your child is getting sick and running into trouble where we need to sort of seek emergency department help. okay? If your child has already been prescribed an oxygen monitor, then please use it because it's a very valuable tool because it'll help you know what your child's normal oxygen saturations are, because then when they're sick, you'll know what's not normal. Okay, so it's a good, helpful tool for you. If your child is using a cough assist device, typically that's prescribed to be used twice a day, every day. And if your child is sick and has more secretions, there's no reason why you can't use that more frequently as needed, sort of tailor with the managing the secretion burden. And finally, if your child has been prescribed a non-invasive ventilator device, like a BiPAP device, typically your child would be prescribed that for periods of overnight sleep. If they're sleeping extra and taking a daytime nap, there's no reason why your child cannot use the BiPAP in the daytime. If they are still so fatigued that they're needing it while they're awake as well, please, please, please make sure you're in connection with your prescribing team. Okay, I'll stop there.
All right, thank you. Next question is for Linda. When should families start thinking about cardiac health and what they can do early to protect the heart?
Thanks, Owen, and thanks for inviting me to be a part of this panel today. It's nice to see familiar faces. I think we need to start thinking about heart health at the time of diagnosis of Duchenne muscular dystrophy. The heart is a muscle like the larger skeletal muscles of the body that ultimately are affected by the lack of dystrophin. So at the time of diagnosis, we should be thinking about heart health and, where possible, referral to either a cardiology team that can advocate for screening or cardiology in the community that can do the screening. So we recommend that screening start at the time of diagnosis. And really from 5 years of age onward, it looks like yearly visits. That would include echocardiography, which is like an ultrasound of the heart. It would include ECG, where we look at the heart rhythm, because each muscle that is responsible for contracting is also responsible for the electricity of the heart. So if the muscle is affected, the electrical system can be affected. And that's really part of routine screening that's recommended yearly. And the reason we do it frequently is because changes in heart function can be silent. And so you may not know that there are changes until we actually do the testing. So we screen so we can detect changes early and intervene where possible. When we think of heart health, there are medications that are available to us. We think of heart protectors. ACE inhibitors are one of them. So perindopril you may be familiar with, lisinopril. We start those around 8 to 10 years of age when children are good at taking tablet forms. And really, there have been small studies, and I think there's more studies that are coming to determine how perindopril helps. But really, it's in those small studies, it showed that it delayed onset of disease when compared to children who were not on ACE inhibitors. So we're really proactive in using medications like this to help keep the heart as strong as possible for as long as possible. Down your journey of cardiac care, there will be other testing that we offer, like a cardiac MRI, which can be challenging when it's difficult to lie still in a machine like that for an extended period of time. But there is value because we get different information that we don't get from echocardiograms, and really a lot of what's been spoken of, it speaks to the fibrosis or the fatty tissue that can develop within the heart, and you just don't see that on echocardiograms. And in fact, you can have early evidence of heart fibrosis that precedes any changes on echocardiogram. So it's just another useful tool that we do recommend. And when we see early evidence of fibrosis, we do recommend starting a medication called spironolactone. it works on a different neurohormonal pathway, so it's not the same as perindopril, but the idea is the same. If we can slow the progression of the fibrosis, keep the heart for as long as possible, then really that's what we aim to do. We do also get Holter monitors, and that's also part of a screening, usually in teenage years or earlier, if we start to see heart rhythm changes, and just open conversations about that along the way. Just to piggyback a little bit off of what Dr. Amin was saying as well, I often like to think about the heart and lungs like a married couple. If one isn't happy, the other one might struggle. So we always, when we see children who are in clinic who've been prescribed respiratory therapies that will help alleviate some of the issues they have during sleep, it's only good for the heart. So we also advocate the use of that when it's prescribed for reasons, for respiratory reasons. I think, did I get everything, Owen? Did I miss anything?
No.
Okay.
Thank you.
Thank you.
Now, this next question is for Dr. Ward. Can you explain how long-term steroid use impacts endocrine and bone health, and what families should be most aware of?
Great. So thank you so much for the questions, and it's great to be among the panelists today. And I'll just start by saying that you're really hearing a theme from among the panelists about early anticipatory prevention or early anticipatory monitoring. And that theme has also very much infused endocrine and bone health care, where we really feel that any individual with Duchenne, whether they're on steroids or not, should have a connection with a pediatric endocrinologist during this age range. It is endocrinologists in Canada who do have the expertise to guide you through the bone health issues in this condition and to guide you through the endocrine issues as well. And this is particularly true if you're on long-term steroid therapy, or even honestly on short-term steroid therapy. There can be endocrine consequences. So I'll reframe that just a little bit and say, if you're on steroids, you should see an endocrinologist to have that anticipatory guidance. And even in the absence of steroids, there can be endocrine and bone issues. So what are the main issues to think about? I'll start from top priority. It's all important, but I'll start with the one that I think is the most important, and that is that steroids can cause the adrenal glands to go to sleep. And I'm going to talk about that in a little while, so I won't go into too much detail. But in anyone receiving steroids, the adrenal glands go to sleep. And the adrenal glands are responsible for making a critical hormone called cortisol that's like the gas in our tank. And we need cortisol for life. We can't live without cortisol. And so the management of adrenal insufficiency and that anticipatory preventative guidance around what to do if you're on a steroid in terms of preventing adrenal crises and preventing from just feeling not well on steroids is a #1 priority. So anyone starting steroids needs a steroid stress dose plan, and I'll talk about that more in the next session, so I won't go into too much detail now. And for that reason, either your neuromuscular physician who's prescribed the steroids needs to do that education at the time of steroid prescription, or an endocrinologist needs to partner with the neuromuscular expert to achieve that. And this is true of vamorolone as well. Vamorolone also causes adrenal suppression, and that is not specific to Duchenne. All these steroids cause adrenal suppression. So that's the first thing. In terms of bone health care, I love your comment that it's like a marriage between the heart and the lungs. There's also a marriage going on between the muscle and the bone. I used to call it like peanut butter and jelly, but I like the marriage analogy, that if one is struggling, the other is probably struggling too. So certainly the Duchenne itself, the dystrophinopathy, can cause the bones to be weak. And then when you layer in steroids, then the bones can be even weaker. And certainly we know that sometimes individuals will have fractures that take them off their feet prematurely. And so we feel that protecting the spine in terms of the strength of the bones and protecting the bones of the other parts of the body is a really important part of Duchenne care. We want to see that an individual with Duchenne
is engaged with a bone health expert early on. We say no later than the time of steroid initiation. So around the time of diagnosis or no later than the time of steroid initiation is when someone should at least have a referral into a bone health expert. And then from there, the bone health expert will monitor bone health, will do some education around that. And when we start to see that the steroids or the muscles are tickling the bones, as I say with the kids, starting to cause the bones to be weak, we actually move to discussions about bone protection therapy. We used to wait until there was a fracture. And families would say to me, why are we waiting until there's a fracture? And I'd say, I know, it just doesn't make any sense. But we didn't have the data, we didn't have the evidence to back up starting earlier, and we do now. We have the evidence that we need to have those conversations with families and say, we're seeing the steroids tickle the bones, and we think it's time to start thinking about bone protection therapy. The standard of care is an IV therapy that we give periodically, and again, it would be a bone health expert that would guide you through that. So those are, I think, two top priorities. And then in terms of growth and puberty, we know that in the absence of steroids and on vamorolone, growth tends to be normal. But on classic steroids like prednisone and deflazacort, the growth plates can suffer and petite stature can result with a deceleration in growth velocity or even growth arrest. And for some families and for some individuals, Duchenne, that is concerning. For others, it's not as concerning, and that's a very personal decision or a personal perception around the extent to which the growth is affecting an individual in their life. But again, an endocrinologist is the one that would talk that through with the individual who has petite stature because of steroid therapy and talk through what the options are. There really aren't any good treatments for short stature due to steroids in Duchenne, although vamorolone does protect against short stature in Duchenne, and so that is something to consider, and I'll talk a little bit more about that later as well. And then puberty is expected to be normal in someone who's not on steroids, who's not on prednisone or deflazacort. We don't know about the effect of vamorolone on puberty yet. But if an individual is taking prednisone or deflazacort at therapeutic doses, we do expect puberty to be delayed. And that's another thing that endocrinologists would talk to an individual about is what is puberty and why is it important to have puberty and what does it mean to have delayed puberty, and provide options around how to help with inducing puberty if it's delayed beyond 14 years of age. Puberty and the hormones that go with that are good for bones, and they're also good for cognitive development and maturity and decision making and judgment. So puberty is another aspect of endocrine health that we take care of as endocrinologists. And I think those are sort of the main talking points. Owen, did I miss anything that you wanted to highlight?
No.
Okay.
All right. This next question is for Charise. How does occupational therapy support everyday life for someone living with Duchenne? And what supports or equipment should people start planning for to stay active and independent?
Okay, thanks, Owen. Occupational therapy is a really, really broad profession. Generally, the goal is to support participation, and so helping kids to do the things that they want to do and the things that they have to do. So that can look like bathing, dressing, the self-care tasks, school, and then also having fun, and some of those things we talked about earlier today. In Duchenne, it can look like lots of different things. So sometimes we're looking at attention and sensory strategies, energy conservation, exploring equipment to support with safety and independence for self-care skills, and mobility equipment as well. And then you wanted to talk about, the second part was about equipment, Owen?
What supports or equipment should people start planning for to stay active and independent?
Okay, so it's an individualized question, and occupational therapy should be very individualized, so it's meant to be supporting your family with goals and things that are important to you, and to support participation. So really should be a partnership with each individual family and child based on what their goals are. What we sometimes see, especially in the kind of 9 to 15 age, is that moving can get a bit harder. And so sometimes we see kids starting to participate less or not join in, or taking breaks and missing things. And so often we'll start talking about mobility devices and wheelchairs to support participation and energy conservation. So that's a really big piece of equipment that's important for supporting the body and then also for supporting participation. We talk a lot about using a chair maybe to get to a park so that you still have energy to play, and then changing and integrating how it's used based on what your mobility needs are. And I would say similarly for any home-based equipment, it's really going to vary based on what you want as a family and what your child wants, what they want for their level of independence. But there's lots of equipment to support with bathing and transfers, toileting, sleeping, accessibility in and into your home and around your home. So it would look lots and lots of different things, just depending on what your family needs.
All right, those are all the questions that I had. I think it's time for questions from everyone else. And yeah, that's it for me.
Thank you so much, Owen. You did a fabulous job moderating all of those questions. So I think we're going to open it up to the audience. Are there any questions that any of you have that you want to ask any one of the panelists? I think we have a question over here.
For Dr. Campbell, do you see, just a question, do you see a benefit in a child that's like older, around the age of 12, switching from deflazacort to, say, vamorolone now that it's approved?
Yeah, that's a great question. And I'm not sure we, entirely, know how this is, going to go. I think those decisions are often best made between yourself and your care provider, depending on what side effects you've experienced or what might be the issues that's driving that decision. Like, I think having just a general statement like, oh, you should switch is not, I don't think we have the data to support that at this point in time. If your child's done very, very well on traditional steroids and you've seen, preservation of their motor skills and they haven't had side effects, then you can still have that discussion, but those drivers wouldn't be there. So I wouldn't say there's just a blanket thing like, oh, everyone should explore that right away. But certainly there are families that have struggled with side effects to vamorolone or to traditional steroids that vamorolone would be helpful for, or who have moved on to reduced dose regimens with the traditional steroids because of that, or and I think those are would be a very good opportunity to talk through the option of vamorolone. Lauren, would you have any other factors or elements to add to that? Yeah.
I have a question when it comes to endocrine and the sleeping adrenal glands. Well, a lot of parents I know have opted for the weekend dosing, and does that allow for the glands to not sleep, therefore have some kind of adrenal reaction? And when it comes to vamorolone and deflazacort, when you look at these two drugs, is that, from my understanding, as of right now, there is a cap on vamorolone as how high the dose can go. And then you can, I think only be up to 50 kilo, and then the dose cannot go any higher as of right now. So then the parents probably have to be switching to deflazacort. And then if they are on daily, they would have to go to daily as well, or is it possible to go to weekend dose? So I guess that's two different questions I have.
Yeah, that's great. Thanks for the questions. These are really, really important questions. So the first question is, if you're on weekend-only classic daily dosing, do the adrenal glands go to sleep? And the answer is that everyone metabolizes steroids differently, and even weekend dosing has the potential to put the adrenal glands to sleep, especially over time. So the guidance we've put out there is that no matter what steroid regimen you're on, whether you're on deflazacort, prednisone, or vamorolone, whether you're on weekend only, twice weekly, daily, every other day, or something else, we assume that you are at risk of adrenal insufficiency. And the reason that we're so extremely cautious is because adrenal insufficiency is a cause of unexpected mortality in this condition. And so we feel that we need to be cautious and make sure that we have a steroid stress dosing plan for anyone that is on glucocorticoids. And then your other question is about dosing and transitioning, right? And whether the cap on the vamorolone means that you need to supplement with some additional steroid. And that is a really good question. I'm not aware that we have guidance on that, but perhaps Craig has information on that.
Yeah, so I can talk a little bit to that. So even with traditional steroids, we don't just continue to push the dose up and up and up as a boy grows. We often make 2, maybe 3 weight-adjusted dose increases. So the dosing with vamorolone actually is not dissimilar to the general practice with most steroids. And in fact, if you look at really all the data from many studies, the benefit of steroids has been shown in groups of boys and young men over their lifespan, but as they're older, the dosing has in most of those cohorts of boys has fallen away from the 0.9 milligram. You'll read 0.9 milligram per kilogram per day, or 0.75 for prednisone, to usually somewhere between 0.4 and 0.6 milligram per kilogram, and still the longer term benefits of steroid are seen. So there's something about treating at those high doses and then letting the dose range drop, and so I would say, in fact, that'll be very similar with the way the structure of dosing of vamorolone is. Does that make sense? Yeah, was that clear?
Mm-hmm. Yeah, excellent.
Just a follow up to that, right? When you say the dosing remains the same as the boys grow older, right? Why not then start at the same lower dosing at an early age? And if the same dosing at 0.4 milligram per kg you said at when the boys gain weight, right? It has shown to have the same impact.
No, sorry. I
misunderstood.
was worried I was not clear. Definitely starting at 0.9 milligram per kilo for deflazacort, or 0.75 milligram. And I'm assuming, although again we're very early days with vamorolone, but the recommended dose, what I'm saying is not that 0.4 or 0.6 have shown the same benefit. What I'm saying is that boys who started at those typical doses, but then followed over time, gradually their dosing tends to end up in a lower dose range over time, just with their growth, so that people aren't pushing the dose up as people grow. And those cohorts of boys in studies that have followed boys for that long term and shown this pattern of relative dose reduction, because the dose isn't actually changed, it's the boys growing that makes it a relative dose reduction. The long-term effects on heart, lung, scoliosis, like some of those long-term benefits that we see are maintained. And so does that Does that frame it better?
Yeah,
Okay.
yeah. So I have another question. Sorry. So now that vamorolone is approved by Health Canada, right? So as doctors, right? Any new clinical trials that will come in, how would we, you as doctors, be pushing for them to include vamorolone in there as a standard of care with prednisone or deflazacort, right? Because that clinical trials would still have to have that before kids take vamorolone and enroll in clinical trials, right? And the second part of that question is, what can be done for the current trials that are kind of starting, ongoing, right, in very early stages to, have that included? Where do we advocate? Where do we say to, these pharmaceuticals, say, you know what, now it has been approved, and they would already be doing that in the States. So can we take that data and accelerate the process from there?
Yeah. So these are excellent questions, and things are shifting often so quickly in the DMD world, and jurisdictionally between regions can be very different. I mean, we've talked enough today about, the fact that we don't have a lot of the same treatments as just a couple hours south of the border. But when things are considered standard of care, and very quickly vamorolone is entering that because of its presence in the US and in the EU, that will be reflected in changes in inclusion criteria and exclusion criteria for clinical trials. So if they aren't there now, then those will be changing very, very quickly, and many companies will make protocol amendments to include that. The other thing, if you are in a clinical trial, it's very clear in the language. I know it's sometimes hard to read these 20-page letters, but for the most part, if something is better for you and available in your jurisdiction, and your physician and you feel that it's better for your child, then those discussions should be had, even in the setting of a clinical trial. Because most clinical trials, they want the boys to be on the best thing, for them. Now, it might mean, thinking carefully about maybe when you make the shift, but that discussion can be had. So I know we often think of, when you get in a clinical trial, you're locked in. But if things change in our information about Duchenne, or things change in the health of your child that make adding a new medication or changing to a medication, then that's important, even in a clinical trial, and that's something that should be discussed.
Thanks a lot.